Today we'll be talking about nutrition during the growing years. As humans move from infancy to adulthood, height and weight increase, body composition changes, and organs mature. Normal growth and development are highly dependent on calorie and nutrient intake. Insufficient calories and nutrients, along with too little sleep and a lack of loving care, can impair the ability to thrive, which would be to grow and develop to the fullest physical and mental genetic potential. When nutrients are missing at critical developmental phases, growth slows and may even stop. As with the fetus, the effects of poor dietary intake in infancy, childhood, and adolescence depend on its severity, timing, and duration. Overall, eating a poor diet during the growing years hampers the cell division that occurs at critical stages. Physical growth rate is at its peak velocity during infancy, which causes nutrient needs per unit of body weight to be at their lifetime highest level. Most babies have doubled their birth weight by 4 to 6 months of age. By their first birthday, they have tripled their birth weight and increased in length by 50%. In contrast to the rapid and usually smooth increases in height and weight of the first year, the physical growth rate of childhood is much slower and occurs in bursts. It is normal for weight and height to remain unchanged for weeks, then suddenly spurt up. Nutrient and calorie needs, as well as the child's appetite, tend to rise and fall in response to these normal growth fluctuations. Healthy children grow a few inches taller each year. Healthy children also gain 4 to 6 pounds or so every year until age 8 or 9. Then the rate of weight gain increases to about 8 to 10 pounds annually until just before puberty, when many children normally store a few pounds of extra body fat. Adolescence is the transition from childhood to adulthood, and it is a rapid phase of physical growth. 1/3 or more of all the growth in a lifetime occurs during this stage. Adolescence starts with the onset of puberty, which on the average begins between the ages of 10 and 13 in girls, and approximately 2 years later in boys. Puberty ends about 8 to 10 years after it starts, when the person is physically mature and capable of reproduction. Early maturing girls may begin their growth spurt as early as age 7 to 8, whereas early maturing boys may begin their growth spurt by age 9 to 10. Most girls reach adult height at age 14 or 15, and most boys reach adult height at 18 years old. As boys and girls move through the growing years, body composition changes too. These changes affect their nutrient needs in different ways. The proportion of body water declines during the first 2 or 3 years of life, at which point it achieves levels similar to those of an adult. The proportion of lean body tissue increases as infants and children grow older. Males and females enter adolescence with similar percentages of lean body tissue. But during adolescence, males secrete testosterone, which causes them to gain more muscle mass, develop a heavier skeleton, and build a greater quantity of red blood cells than females. By the end of adolescence, females have 2/3 as much lean body tissue as males. The proportion of body fat rises from birth to age 1, then declines slowly until age 7, when it begins to gradually increase again. During adolescence, body fat continues to rise in females, but it declines in males. This is because females secrete estrogen, which stimulates the accumulation of subcutaneous fat. This body fat is essential for sexual maturation. When a female's body fat equals about 16 to 17% of body weight, and her body weight reaches about 100 pounds, menstrual periods begin and become regular once body fat reaches approximately 22%. The increasing regularity of the menstrual periods indicates that a female is nearing adult levels of body fat, is ending her growth. When adolescence ends, females have twice as much fat as males. In addition to the obvious outward changes in weight and height, babies, children, and teens are maturing inside. During infancy, the kidneys double in size and begin to eliminate waste more efficiently. The stomach gradually increases its capacity and begins secreting digestive enzymes. By about age 4 to 6 months, the digestive tract has matured greatly too. These changes enable infants to eat larger amounts of food at mealtime and use nutrients from a greater variety of foods than just human milk or infant formula. Organs continue to grow and develop throughout childhood, with many reaching their full adult size and function during this stage. The single best indicator of a child's nutritional status is growth. Healthcare professionals use growth charts matched to the child's gender to determine if growth is progressing normally. They have several percentile curves because children grow at different rates, many of which can be considered normal. The percentile curve a specific child follows depends on dietary intake and genetic potential. A child who is adequately nourished and has tall parents may fall in the 90th percentile for stature for age and 75th percentile for weight for age. By having several percentile curves, healthcare professionals can compare a child's growth with the growth of others at the same age. If a boy's stature for age falls at the 25th percentile, he is shorter than 75% of the other boys of the same age. If a girl's weight for age is at the 95th percentile, she is heavier than all but 5% of girls of the same age. If a child's BMI for age is at the 50th percentile, the child has a lower BMI than half of all children of the same age. Growth should be tracked over time to identify a child's growth percentile and determine if growth is progressing normally. It takes 1 to 3 years for an infant to establish his or her own percentile. Once growth percentiles are established, a healthy child who is eating a nutritious diet will maintain about the same percentile curves from year to year. Small growth spurts and lags are expected, but a sudden jump up or down 2 or more percentile curves may signal that a child is experiencing growth problems caused by calorie excesses or deficits, nutrient inadequacies, illness, or psychosocial problems. For example, a child begins overeating. BMI for age may jump several percentile curves up. When the BMI for age reaches the 85th percentile, the child is overweight. When it reaches the 95th percentile, the child is obese. At the 95th percentile, the diagnosis of obesity can be established if a physical exam that the child is truly overfat, which is generally the case at this percentile. In earlier physical checkups, a health professional usually measures the head circumference as another means of assessing growth, especially brain growth. The brain grows faster in infancy than in any other time of life, with this rapid growth ending at about 18 months of age. How nutritional status affects brain development and intelligence quotient, which is IQ, is difficult to measure because scientists haven't figured out how to separate the effects of nature from those of nurture. However, several studies have determined that breastfed infants have higher IQs than infants fed with infant formula. At the same time, studies from Central America suggest that IQ after age 5 years relates more closely to the amount of schooling a child receives than to nutritional intake during childhood. A child's growth rate reflects calorie and nutrient intake. BMI for age, or weight for length for children younger than 2 years old, is a good indicator of recent nutritional status. An insufficient diet is the immediate past causes a drop in BMI because weight decreases while height stays relatively the same. Excessive calorie intake results in a rise in BMI because weight increases without a corresponding increase in height. Stature for age is a good indicator of long-term nutritional status because undernutrition usually must be prolonged before stature is affected noticeably. Infants and young children who do not grow at the expected rate for several months and are dramatically smaller or shorter than other children at the same age, especially those who fall below the 5th percentile, are said to experience failure to thrive. Although physical abnormalities such as heart defects and cleft palate, infections, intestinal problems, and hard-to-diagnose inborn errors of metabolism cause some cases of failure to thrive, nutrition or feeding problems are the cause of many cases. Failure to thrive may be a result of lack of access to sufficient or appropriate food, physical problems, poor feeding techniques, mental depression in the mother, negative socialization, lack of cuddling, voices, and eye contact. Long-term effects depend on the severity and the length of time of malnourishment. Growth in height ceases when the epiphyses fuse. This process begins at around 14 years of age in girls and 15 years of age in boys, and it ends about 5 years later. For these reasons, a 16-year-old undernourished girl who is 4 feet 8 inches tall cannot attain her full adult height simply by eating better. She will be able to increase the diameter of her muscles, but overall muscle growth will be limited by the length of her bones. Catch-up growth is possible even when growth retardation has been severe and prolonged, if the epiphysis has not been closed. All of the changes that occur during the growing years influence energy and nutrient intakes and needs, but growth rate has the greatest effect. The faster the growth rate, the greater the nutrient and calorie needs per pound of body weight. The greatest needs pound for pound occur during infancy, when growth is at its peak velocity. Although calorie and nutrient needs per pound of body weight steadily decline after infancy, the total quantity of calories and nutrients needed rises throughout childhood because the body grows larger. During puberty, nutrient needs like growth rate increase sharply, and gender differences in nutrient needs become more obvious. During puberty, nutrient needs again increase sharply. Males need more because of development of muscle and bone and longer, more intense periods of growth. The rapid growth and high metabolic rate of infants and toddlers cause their calorie needs, pound for pound, to be 2 to 4 times greater than adults. Calorie needs for metabolic rate are high mainly because an infant's body has a large surface area, which allows a great deal of body heat to be lost. Many calories are used to keep the body warm. Newborns need approximately 50 calories per pound each day to support their rapid growth and high basal metabolic rate. After 2 to 3 months of age, calorie needs drop to approximately 40 calories per pound daily and remain about this level until age 3 years or so. The slower growth of childhood in comparison with infancy translates into a gradual reduction in calorie needs per pound of body weight. Calorie needs per pound decrease to 32 by age 5 and drop to about half that amount by age 15. Infants need approximately 1.5 grams per kilogram per day of protein, and this supports the rapid growth of tissue. During childhood and adolescence, protein needs per pound of body weight are 20 to 40% higher than for adults. Children 1 to 3 years old need 1.1 gram per kilogram a day of protein. Older children need 0.95 grams per kilogram per day of protein. Deficiencies can have lifelong consequences. Physical development will be impaired if protein intake is inadequate or if calories are restricted to the point that protein must be used for energy. Inadequate protein intakes are uncommon in technologically developed countries, such as the United States and Canada. Only excessive dilution of infant formula with water or severely restricted food intake is likely to lead to low protein intake. Dietary protein inadequacies are a leading contributor to childhood illness, delayed or stunted growth, and death in developing countries. Fat is an important part of infants' diets. It provides constituents such as cholesterol and essential fatty acids. Because it contains many calories in a small volume, fat can meet infants' high calorie demands without overfilling their small stomachs. Total fat should account for 40 to 55% of a baby's calorie intake. Infants, as well as children and teens, need at least 5 grams of essential fatty acids each day. Dietary recommendations are meant to reduce the risk of heart disease, do not apply to children younger than 2 years old unless children are at an increased risk of heart disease. Many health experts, including those from the American Academy of Pediatrics and the National Cholesterol Education Program, warn against low-fat diets before age 2 because they can deprive young children of nutrients and calories and impair growth. Most health experts believe it is wise to reduce fat intake gradually between ages 2 and 5 until children are getting an average of 30 to 35% of their calories from fat. Lactose is the primary carbohydrate in the diets of most infants. Starch intake increases when solid foods such as baby cereals and vegetables are added to an infant's diet. Once the diet includes foods other than human milk or infant formula, children should slowly increase their starch intake to equal about half their total calorie intake and limit simple carbohydrate intake. Many children and teens consume much larger amounts of simple carbohydrates than recommended. Fiber intake recommendations for children less than age 1 are not yet set. After age 1, the daily adequate intake is 14 grams of total fiber per 1,000 calories eaten. Many children in the United States do not consume sufficient fiber. High fiber diets are not recommended for children because they tend to be high in bulk and inadequate in calories. They also may bind minerals and block absorption to the extent that deficiencies occur. Babies' need for water per pound of body weight is greater than older humans. Babies have increased surface area. They proportionally have more body water. Their body water turnover is 7 times faster. They have high metabolic rates, which produce more waste, and kidneys are only half as efficient. The need is usually met by breast milk or formula. Too much can lead to water intoxication. The limit for supplemental fluids is 4 ounces a day. Healthy full-term infants are born with internal iron stores, but by the time birth weight has doubled, by 4 to 6 months of age, those iron stores are depleted. If the mother is iron deficient during pregnancy, these iron stores will be exhausted even sooner. To maintain a desirable iron status, the American Academy of Pediatrics recommends that breastfed infants receive iron supplementation and formula-fed infants be given an iron-fortified formula starting at birth. Children 1 to 2 years old are particularly vulnerable to iron deficiency anemia because their diets often are dominated by milk, which is a low iron food, and most are no longer receiving iron-fortified formula. They also typically do not like meat or have difficulty chewing it. In some cases, intestinal parasites contribute to iron deficiency. Iron-fortified cereal and easily chewed meats such as ground beef can help children boost iron intake. Serving iron-rich food with vitamin C-rich food also increases the absorption of the mineral. If deficiency develops, iron supplements should be used under a physician's guidance. Potassium is a nutrient of concern for many children as well as adults. A diet rich in fruits and vegetables can help children and teens meet their potassium needs. Calcium intake and weight-bearing exercise throughout the growing years are important to forming strong bones. Calcium needs rise sharply starting around age 9 years and remain high until the end of adolescence because the bones are growing longer and denser. The majority of bone formation occurs between the ages of 9 and 18. Less than optimal calcium intakes can lead to decreased bone density and a greater risk of osteoporosis later in life. Unfortunately, teens' calcium intake usually falls well below the RDA, although males are more likely to have adequate calcium intake than females. Many teenage females replace calcium-rich milk, which they perceive to be fattening, with calcium-poor soft drinks. Fluoride supplements are recommended between 6 months and 16 years old if drinking water is low in fluoride. Although zinc deficiency does not appear to be a problem, some children and teens in the U.S. may be consuming too little. Low intakes occur because children consume small portions of rich sources, such as meat. Breakfast cereal fortified with zinc can help improve this mineral. The diets of many older children and teenagers are low in folate. This is probably because their vegetable intake tends to be less than recommended. Also, during the teenage years, meals frequently are eaten away from home compared with foods prepared at home. Cafeteria and restaurant foods tend to be lower in folate, as well as vitamins A and C. Insufficient intakes of these vitamins may impair normal growth. Vitamin D is important during the growing years because of its role in normal bone development. A lack of vitamin D will lead to the bone deformations seen in rickets. Ample vitamin D is provided by brief exposure to sunlight daily. When sunlight exposure is limited, which is often the case in northern latitudes, dietary vitamin D is needed. Fortified milk can supplement vitamin D for children and teens. Infant formula supplies vitamin D to infants, and the American Academy of Pediatrics recommends that infants receive a vitamin D supplement. Infants are at a risk of vitamin K deficiency because they are born with little or no vitamin K. The vitamin K producing bacteria that thrive in the intestines begin to grow when a baby is fed for the first time. However, it may take several weeks for the bacteria to multiply. So in the meantime, infants have a low vitamin K level and may experience slow blood clotting and unchecked bleeding. It is recommended that all infants receive a dose of vitamin K at birth, and some state laws require it. Supplements are not recommended unless children and teens are poor eaters, vegan, pregnant, needing to manage obesity, deprived, neglected, or abused. Some special circumstances is vitamin K for newborns, iron supplement for breastfed babies, vitamin B12 for breastfed babies of vegan mothers, vitamin D for infants, and fluoride if the water is unfluoridated. Parents of a new baby have 1,000 things to do, but menu planning isn't among them. With few exceptions, human milk or iron-fortified infant formula, coupled with the internal nutrient stores the baby built during fetal life, should meet an infant's nutrient needs at least until age 4 to 6 months. The decision to breastfeed, formula feed, or feed a baby a combination of these is personal. There are many valid reasons why selecting either human milk or formula, and both enable babies to grow normally. It is recommended to breastfeed exclusively for the first 6 months. Human milk is the most ideal and desirable source of nutrients. Breastfeeding for any amount of time is beneficial. The continued combination of breastfeeding and feeding an infant food until age 1 year age is recommended. The World Health Organization goes beyond that to recommend breastfeeding for at least 2 years. Surveys show that only 79% of North American mothers begin to breastfeed their infants in the hospital, and at 6 months, only 49% are still breastfeeding their infants, dropping to just 27% by 12 months. Breastfeeding for the recommended length of time is best, but breastfeeding even just the first few weeks is beneficial. Human milk may share many similarities with the milk from other mammals, but its nutrient composition and bioavailability are uniquely engineered by nature for human babies, just as cow milk is designed for calves and sheep milk is designed for lambs. Unless altered, milk from cows or other animals should never be fed to infants younger than 12 months old. Except in cases of severe maternal malnutrition or other special cases, human milk contains ample supplies of all the nutrients needed until age 6 months, except possibly for vitamin D, iron, and fluoride. The protein in human milk is mostly synthesized by breast tissue. Some proteins, such as immune factors and enzymes, enter the milk directly from the mother's bloodstream. The major proteins in human milk are easier for the infant to digest and less stressful to the immature kidneys than is the protein in cow milk. The proteins in human milk are not likely to cause allergic reactions in infants, so breastfed babies are less likely to develop allergies and food intolerances than formula-fed babies. Another human milk protein, lactoferrin, increases the rate of iron absorption by the infant. As a result, more iron is absorbed from human milk than infant formula or milk from other animals, even though human milk contains less iron than these foods. Lactoferrin also protects against harmful bacteria. The fats in human milk come from the mother's diet and are synthesized by breast tissue. The mother's current and long-term dietary intake of fat affects the profile of fatty acids of her breast milk. Human milk is high in cholesterol and linoleic acid, both of which are required for normal brain growth and development. It also contains omega-3 fatty acids, which are needed for normal development of the retina in the eye and nervous system tissue. The lipids in human milk also promote efficient digestion. Lactose is the main carbohydrate in human milk. The sugar galactose is synthesized in the breast, whereas glucose enters from the mother's bloodstream. Human milk composition provides adequate water for the infant when the baby is exclusively breastfed. Commercial iron-fortified infant formulas provide a safe, nutritious alternative to human milk in areas of the world where high standards for water purity and cleanliness are common. Only formulas that are commercially made specifically for infants are safe to use. It is important to note that milk, such as cow, goat, or soy milk, sweetened condensed milk, evaporated milk, and homemade formulas are inappropriate choices for infants. They do not conform to the strict federal guidelines for calorie content, nutrient composition, and sanitation, and as a result can cause life-threatening problems. Infant formulas generally contain lactose and/or sucrose for carbohydrate, vegetable oils for fat, and modified proteins from cow milk, soy, or meat. A wide variety of commercial infant formulas are sold to meet the various health needs of infants. Soy-based infant formulas are available for infants who can't tolerate lactose or proteins in cow milk-based infant formulas. Infant formula made with protein that has been pre-digested or broken down into peptides and amino acids can help infants with digestive problems. Formulas that address the special nutrient needs of preterm infants are available. Other more specialized formulas also are made for specific medical conditions, such as PKU. In addition to the nutritional and immunological differences described, human milk and commercial formula also differ in the terms of health benefits, costs, convenience, and possibly mother-child bonding. The health benefits of human milk for infants are not limited to its nutritional contributions. Factors in human milk promote the maturation of the immune system and intestinal tract. Breastfed infants have a reduced risk of childhood asthma, obesity, diabetes, intestinal infections, misaligned teeth, ear infections, respiratory infections, and sudden infant death syndrome. They are also less likely to be obese in childhood and adolescence than formula-fed peers. There is also evidence that children who were breastfed have significantly higher visual acuity and cognitive development scores than those who received no maternal milk. As the amount of human milk an infant receives during the first 6 months of life increases, the risk of developing health problems decreases. Human milk is almost always less expensive than formula, even after accounting for the cost of breast pump equipment and the slight increase in food required by the mother. Whether breastfeeding is more or less convenient than formula feeding depends greatly on the circumstances. Preparing formula requires considerable time, careful sanitation, and exact measurements. Human milk, which requires no preparation, is much more convenient to prepare. However, if the mother wants to feed her child human milk during time she is away from the child, she will need to express her milk and store it in bottles. The preparation time and sanitation measures needed for this are similar to those needed to prepare formula. Mother-child bonding is a benefit frequently attributed to breastfeeding. It is true that breastfeeding requires an intimate physical relationship between mother and child that helps form a strong emotional bond. However, bonding depends more on close physical contact than on method of feeding. Formula-fed babies and their mothers also can develop a strong bond if the babies are held during feeding. Infants usually need 2 or 3 ounces every 2 to 4 hours, and they follow closely during the first week of life to ensure feeding and weight gain are normal. You should not encourage the baby to eat more than is desired. This teaches them to overeat, and it may cause stomach pain. You can watch for a signal a baby is satisfied, when they turn their head away, being inattentive, falling asleep, or when they become playful. A well-fed breastfed infant should have 6 or more wet diapers daily, show signs of normal weight gain, and pass 1 or 2 stools per day. You should burp the baby after 10 minutes of eating or feeding 1 to 2 ounces from a bottle. All equipment used to prepare, store, and/or feed babies should be thoroughly washed and rinsed. Prepare formula exactly as the instructions dictate. Use only clean, cold water. Hot water poses risk of lead content. Boiled well water prior to using. Prepared formula and breast milk can be refrigerated for 1 day. Human milk can be frozen for several weeks. Discard any leftovers in a bottle. It can become contaminated with bacteria and enzymes. As babies grow, the nutrient reserves they had at birth become depleted, and human milk alone can no longer meet all their nutrient needs. Slowly, they need to begin getting some of their nutrients from solid foods. Although iron-fortified commercial infant formulas can meet the nutrient needs of infants 6 to 12 months old, infants older than 6 months of age rarely are fed just infant formulas. Adding solid foods helps ensure that any as of yet unknown nutrient needs are met. An added bonus to exposing babies and children to a wide variety of food is helping them develop a willingness to taste new foods and learn to eat a widely varied diet. The more varied one's diet is, the more nutritious it is likely to be. Most babies are ready for solid food at 6 months. Food can be introduced based on their nutritional need. The nutrient stores a baby had at birth are exhausted by the time an infant has doubled his or her birth weight and weighs at least 13 pounds. A breastfed infant needs solid foods when he or she demands to be fed more than 8 to 10 times each day. If solid foods are delayed much past the point of 6 months old, a baby has a nutritional need for them. Growth will slow. The physiological capabilities. The kidney function is quite limited until about 4 to 6 weeks of age. Until then, waste products from excessive amounts of dietary protein or minerals can cause so much urine output that dehydration occurs. Because infants can easily absorb whole proteins until 4 to 5 months of age, exposing them to many different proteins before then, especially those in unaltered cow milk and egg whites, may predispose a child to future allergies and other health problems. For this reason, it's best to minimize the types of proteins in a young infant's diet by focusing exclusively on human milk or infant formula. Their physical ability. Young babies do not have the coordination to swallow solid food safely. These foods may cause young babies to choke or inhale food into the lungs. Several signs indicate that babies are developmentally ready for solid foods. These abilities usually occur around 4 to 6 months of age, but they will vary with each infant. They can control their head movements and sit alone without support. Their extrusion reflex weakens, and they can make a chewing motion. The American Academy of Pediatrics has issued the following guidelines: exclusive breastfeeding for the first year. Bottle feeding, you should use the appropriate bottle feeding practices, so avoid bottle propping. Feed only breast milk or formula in a bottle unless otherwise directed by a physician. Introduce solid foods around 6 months of age. Expose the baby to a wide variety of healthy foods. Offer a variety of textures. After 9 months, offer 2 to 3 healthy and nutritious snacks per day. Maintain fruit and vegetable intake after finger foods are introduced. You should foster self-feeding by encouraging babies to use spoons and fingers to feed themselves. Encourage babies to drink from a cup starting at 6 months of age. Parents should recognize hunger and satiety cues. For healthy drinking, babies should drink breast milk or formula for the first year of life. Try to avoid introducing juice until child is a toddler. If juice is introduced, wait until 6 to 9 months and limit consumption to 4 to 6 ounces. Avoid the introduction of sugar-sweetened beverages. Between 6 and 12 months of age, human milk or formula intake gradually decreases, while solid food intake slowly increases. Initially, solid foods are a very small addition, such as 1 to 2 teaspoons, to the diet. As the baby's first birthday approaches, calories should be evenly divided between human milk or formula and a variety of foods from all the major food groups. Experts recommend slowly adding foods with just one ingredient and waiting several days before offering another new food. This method makes it easy to identify food sensitivities and allergies by watching for reactions such as gas, diarrhea, vomiting, rash, and breathing problems, such as wheezing. If the baby is fed new foods too often or is fed a food with several ingredients, before each ingredient has been offered alone, there is no way to tell which has caused the problem. If a symptom appears, the suspected problem food should be avoided for several weeks and then reintroduced in a small quantity. Common foods that cause allergic reactions are egg whites, chocolate, nuts, and cow's milk. The recommended sequence for introducing solid foods is designed to respond to the physical maturation and increasing nutrient needs of infants. Iron and vitamin C are the first nutrients needed by infants in quantities larger than those supplied by human milk. The first solid food generally recommended is iron-fortified baby cereal. Pureed fruits and vegetables are the next foods usually introduced. Fruit is often introduced at about the same time as cereal. Cereals and fruit juices marketed especially for babies are the preferred choice because they have no added salt, sugar, or monosodium glutamate. The iron in infant cereals is much more absorbable than that found in adult cereals. Baby juices are fortified with vitamin C, which promotes iron absorption. And rice usually is the first cereal introduced because it is least likely to cause allergies. Orange juice may be too acidic for infants, and it is not recommended until age 1. Protein-rich foods such as pureed meat, fish, chicken, beans, yogurt, egg yolk, and tofu were introduced around age 6 to 8 months. These foods help supply the increasing amount of protein needed by the rapidly growing infant. It's usually best to wait until the child is a year old before serving egg whites or unaltered cow milk because they frequently cause allergic reactions in younger babies. Once cow milk is added to a child's diet, the American Academy of Pediatrics recommends that the child receive whole milk until age 2 years or older. Children who receive reduced fat milk before age 2 years have difficulty meeting their calorie needs without exceeding their protein needs. After age 2 years, parents should consult with their child's healthcare provider before switching to reduced fat milk. Lumpy or chopped foods can be introduced when teeth appear. When juices are added to an infant's diet, they should be offered in a sippy cup with a wide flat bottom. Drinking from a cup helps begin weaning. To begin preventing feeding problems and the overconsumption of milk, juice, or other sweetened beverages, babies should be completely weaned off bottles by age 18 months. Using a cup also helps prevent early childhood dental caries. You should not put infants to bed or prop up a bottle when a child is in infant seats, as this increases the likelihood of dental caries and ear infections. Infants begin to learn to feed themselves in late infancy and continue to develop these skills into the preschool years. These self-feeding skills require coordination and can develop only if the infant is allowed to practice and experiment. It's important that parents be patient and supportive, even though self-feeding is inefficient and very messy. Infants are solely finger feeders and don't always hit the target of their mouths. By the end of the first year, finger feeding becomes more efficient and chewing is easier as more teeth erupt. By age 1 year, children drink from a cup without help, which makes fewer bottle and/or breastfeedings necessary. By age 2, children can manage lifting, tilting, and lowering a cup quite well. In addition to this, they are fairly accomplished spoon feeders. By age 3 or 4, they can use a fork, and by age 4 or 5, they can use a knife to cut soft foods. Colic is sharp abdominal pain in otherwise healthy infants. The infants have repeated crying episodes, lasting 3 or more hours, that don't respond to typical remedies, such as feeding, holding, or changing diapers. Colic affects about 10 to 30% of all infants, starting at about 2 to 6 weeks of age and lasting until about 3 months of age. Crying episodes typically occur in the late afternoon and early evening. Nighttime sleeping also is usually disturbed by crying spells. Many colically infants have flatulence, clench their fists, hold their body straight, drop their legs, and want to be held. The cause of colic is unknown. Many infants develop gastroesophageal reflux, more commonly known as spitting up, during their first year of life. In most cases, GER develops before age 2 to 3 months and usually resolves on its own by the time an infant is 12 months old. This problem occurs because the lower esophageal sphincter does not close completely, which allows milk or food in the infant's stomach to move back up into the esophagus. A milk allergy is when cow's milk contains more than 40 proteins that can cause an allergic reaction in infants. Although some of these proteins are inactivated by heating milk, others are not. A true milk allergy develops in about 1 to 3% of formula-fed infants. These infants may experience vomiting, diarrhea, blood in the stool, constipation, and other symptoms. These babies can be switched to a soy-based formula if an allergy is suspected, and most milk allergies resolve by age 3. When a baby sleeps with a bottle filled with formula, milk, juice, or a sweetened drink, the liquids dripping from the nipple pool in the mouth and back up in the throat and the tubes leading to the ears. This backup can promote bacterial growth, which can result in painful ear infections and possibly hearing loss. Many ear infections can be prevented by never allowing a child to take a bottle to bed. After the common cold, dental cavities are the most common childhood disease. Cavities form when bacteria in the mouth metabolize sugars and starch and form acids that erode tooth enamel. Early childhood caries, which was formerly called nursing bottle syndrome or baby bottle tooth decay, is a likely consequence when babies and children sleep with a bottle in their mouth. Diarrhea in infants can cause dehydration. The symptoms of dehydration include dry mouth or tongue, few or no tears when crying, no wet diapers for 3 or more hours, irritability and listlessness, sunken eyes and cheeks. You can prevent dehydration by giving fluids with electrolyte replacements. The children that are at the greatest risk for nutritional inadequacies include those with poor eating habits, vegans. They need to plan their diet carefully to include nutrients best obtained from animal sources. Those with limited resource families. WIC can provide help for children up to 5 years old, and they can also participate in the school breakfast program and national school lunch program. Children tend to have erratic appetites based on growth patterns. Negative results occur when children are bribed, forced, teased, or tricked into eating. Should teach children to listen to their hunger and satiety signals, and make mealtimes happy, social, and enjoyable. Children have small stomachs. They should be offered 6 small meals, which helps meet their nutrient and calorie needs and keeps their blood sugar levels high enough. Breakfast and healthy snacks are important. A serving size for children is equal to 1 tablespoon per 1 year of age. Children age 2 and 3 should be consuming 1,000 to 1,400 calories per day. Children age 4 and 5 should be consuming 1,200 to 1,600 calories a day. Children aged 6 to 8 should be consuming 1,200 to 2,000 calories a day, and older children should be consuming 1,600 to 3,200 calories per day. Food preferences begin to be established during fetal life and continue to develop in the years spanning infancy and adolescence. In the early childhood years, the family usually has the greatest influence on the development of food preferences and habits. As children grow older, peers and teachers begin to provide new ideas about food, eating, and nutrition. Television programming and advertising also present strong lessons about food and eating. Steering children toward healthful foods is likely to be more successful if parents understand the eating behaviors of young children and expose them to nutrition education. The most important nutrition lessons for children of all ages involve expanding their familiarity with new foods and helping them develop a willingness to accept new foods. Teaching these lessons is challenging because children tend to reject unfamiliar foods, but the nutritional rewards of a varied diet are worth the effort. You should try a 1-bite rule where a child takes 1 bite of a new food, and let children make some decisions and involve them in preparation. It may take 15 to 20 exposures before a child accepts a certain food. Many preschool children go through periods of unpredictable and unusual eating behavior. One of the most common is food jags, which is demanding the same meal 3 times a day for a week or more. Food jags can be monotonous, such as eating only green foods or only peanut butter and jelly sandwiches, but generally don't present a nutritional problem unless the food demanded is excessively high in sugar, fat, or sodium, or if the jag lasts longer than a few weeks. The best way to handle most food jags is to serve the food demanded while keeping in mind that the food jag will soon pass. If a child refuses to eat, do not overreact. Children rarely starve themselves. Have the child sit at the table for a while to see if they become interested. You should not nag, force, or bribe a child to eat, as tension can contribute to eating problems. As the teenage growth spurts begins, teenagers begin to eat more. The types and amounts of foods recommended for teenagers are the same as those for adults, except that teens have a greater need for calcium-rich foods. Teens eat less than recommended amounts of fruits and vegetables, and they tend to choose foods higher in cholesterol, sugar, fat, saturated fat, trans fat, protein, and sodium. Soft drinks may replace milk consumption, so teens may not get enough calcium. Their diets may be less optimal because teens eat out frequently, skip meals. More than half of teens skip breakfast most of the time. They snack from vending machines, convenience stores, or fast food restaurants, and it makes up 25% of their caloric intake, but the snacks they're consuming have limited nutritional value. Teenagers are concerned with their body image, and they're concerned about their physical changes from adolescence, peer pressure, messages from the media, the struggle to develop self-identity. Boys may opt for high-protein diets and supplements to produce more muscular physique, and girls often perceive themselves as being larger and want to lose weight. Some other factors that are affecting teens' food choices is athletics and physical performance. Despite participating in sports, many teens' diets do not contain calories and nutrients needed to support activity and growth. They should not restrict the diet of any nutrients or calories. Substance use is common among teens, and their diets may include empty-calorie food. Alcohol alters metabolism and increases the need for and/or excretion of nutrients. Cocaine and nicotine suppresses hunger, and marijuana distorts appetite.